Hello and welcome to the Next Complete Physio podcast. I'm really excited to do today's podcast. I'm joined here by Henry, who is a consultant upper limb surgeon. And with Wimbledon coming, our topic for today is all about tennis elbow. So Henry, do you want to just introduce yourself?
Thanks, Chris. Thanks for the introduction and for the invitation. My name is Henry Colaco. I'm an upper limb surgeon. I specialise in shoulder and elbow surgery, sports surgery, arthroplasty surgery, trauma, and also hand and wrist trauma as well. So, pleasure to be here.
Excellent. Thanks for coming. So we see loads of tennis elbow. We've seen lots of the same patients with tennis elbow. And although it's so common, it can actually be quite a tricky condition to treat. And often people are still getting pain many months after the onset of their pain. So should we just start at the beginning? What is tennis elbow?
So it's got different terminology to describe it, but it's essentially what you will feel is you feel pain coming from that lateral side of your elbow. And it comes from the common extensor tendon, where you have all the extensor tendons that come down your forearm, down towards your wrist and your fingers. And that's the first thing you'll feel. You'll feel it on certain movements, and it may well have been triggered by tennis.
Yeah, it's not always tennis, is it? It's actually we probably see it more in non-tennis players. Would you agree?
True, that is very true. So in the general population, I think it's about 1 to 3% in a lifetime that you get tennis elbow. Yeah. And in tennis players, it's about 40 to 50%. So it's very high in tennis players. Really common.
Yeah. Okay. And so you've talked about, so basically it's a tendon problem and where the tendon attaches onto the outside of the elbow. There's two types, isn't there? There's patients that just sort of get a gradual build-up of pain. And then there's also patients that have a sudden incident. Do you want to just talk through what that might mean or how they present?
Yeah, and sometimes it can be both. So you can kind of have a chronic problem, you can have some kind of background pain, niggle, and then you do something and suddenly, bang, it just flares up. It's other terminology for it is lateral epicondylitis, because that little bit of bone there at the end of your humerus is called the lateral epicondyle. Although it's not really inflammation of the bone, you can get a bit of reactive inflammation or edema in the bone, but really it's a problem with the tendons. And the key thing with tennis elbow, it's called epicondylitis, and itis often implies inflammation, like an inflammatory cause. But in most cases, it's not inflammatory at all.
Yeah. And they used to call it itis, and that indicates that, things like anti-inflammatories would help, or steroid injections, which is a strong anti-inflammatory. But I suppose over the last probably more than 10 years now, we have changed our approach with this slightly, haven't we, in terms of what sort of treatment that we do. So let's just go back. So who gets tennis elbow? Are there any risk factors?
So risk
factors.
Tennis is probably the biggest one. But actually it's often just repetitive tasks. Yeah. So you get a manual job, if it's kind of light manual, heavy manual, even lots of computer work can trigger it. Yeah. And it's just this repetitive tasks, and it's an overload problem. So when you get overload of a tendon and the forces, the repetitive movements and things that you're putting through that tendon and through that muscle tendon junction, you start to get overload. So you're just overloading that area. And so a lot of the treatments are trying to offload it and then try to trigger a healing process.
And do you see it in certain ages? Is it more common as we get older, like most tendon problems, do you think?
Yes, it is.
Everything gets a bit worse as we get older, doesn't it?
Sadly.
Yeah.
It is. And it's that kind of 40s, 50s kind of decades when you get it, when people are still really active and fit and doing lots of stuff and, doing sports. Yeah. And you've got high demands, but your tendons don't have that same regeneration capacity. Yeah. And when you start to lose that a bit, that's when you tend to kind of present with this problem.
Yeah. So let's say they think they've got tennis elbow. How do you know? How do you diagnose this condition?
So the history is very important. And often it's a really simple history. They'll come in and say, I've got this really bad pain over here. Yeah. And that is nearly always tennis elbow, unless you prove otherwise. Yeah. So in order to make a diagnosis, you've got the history from the patient, you've got your clinical examination, and then you've got other tests, so imaging tests. Yeah. But if we just stick with the history, and particularly with tennis players, it may start when they maybe change a racket. They change their string tension, they change the grip size, they change something about their training, or they start taking up paddle and they don't realize it's kind of different. The grip is different. The game is slightly different. The movements are different. Or they're doing both and they're kind of switching between the two, and that can often be a trigger. So they describe the pain over the location, and it's any loading of that tendon. So when you examine them, you want to try and provoke that. And so you want to make sure they've got a good range of movement. Often they'll have pain as they go towards the end of extension. It's painful. They'll have tenderness in that region. And it's not often right on the bone. It's just a little bit further down than that. And that's classically where you have that pain and that tenderness.
And certainly people, if they knock their elbow on a door or something,
it's incredibly painful.
Yeah.
Sometimes, not very commonly, you do have an inflammatory component. Particularly if you have an associated injury which triggered it. So that does sometimes happen.
And certainly if somebody had a big fall or, you know, had done something, then it's got to be checked out, doesn't it? Because not all outside of the elbow
because
pain
it's
is
not
tennis
always
elbow.
tennis elbow, right?
Exactly.
And so
what would you do with a patient? Do it on me. What you would do with a patient to sort of test whether or not they're getting the pain. Be gentle, Henry.
So again, you just want to examine the elbow, so you want to feel that lateral side. You want to feel those tendons, and you'll just feel a tender spot, and it'll be really obvious and pinpoint tendon. And then what we want to see is if these muscles that attach here, they do extension of the wrist and the fingers. And they also do supination. So you've got the supinator, which is a little bit deeper. But again, that can be associated. So what you do is you get your elbow like that, get them to cock your wrist back, and then hold it there, hold against me, pull it, and they'll get sudden pain. Stick your middle finger out, give me the finger, keep it up. Again, resist that.
That's always sore, isn't it?
Very specifically painful. Not always, and sometimes one's painful and the other isn't. And then if you hold my hand, and what I'm going to do is I'm going to turn your hand. It's a quite warm room. Keep your hand facing the ceiling. Keep your elbows straight. I'm going to try and twist it down to the floor, and you just resist that twist. And if you just get a sudden bang of pain, then again, if you got all three of those, that's
so if you've got that, do you need imaging, or is that enough to say? I assume that would be enough to say, well, you've probably got tennis elbow. Let's get on with treatment, or what would you do?
Maybe because I'm a surgeon, I will always get imaging because you want to confirm the diagnosis.
And rule out other joint
And you definitely want
issues.
to rule out other things. And sometimes it can be something else.
Yeah.
You can have a combination of different imaging. So you could have an X-ray, particularly if you've got an older patient, you think they may have a little bit of arthritis.
Yeah.
It'll also show if there's a traction spur on the bone, which shows that might have been going for a long time. You get a traction enthosopathy, and the bone can kind of
so that's a bit of extra
the tendon.
A
little bit of extra bone where the tendon kind of pulls on it over time. So X-rays and an ultrasound scan could give you a lot of information, or an MRI scan.
And what are you looking for there, particularly in reference to the tennis elbow? Is there anything specifically you're looking for that gives you an idea as to maybe how long they've had the problem or how easy it will get better?
So you're looking for confirmation of the diagnosis. So you're looking for kind of degeneration within that tendon. And you're not really looking for inflammation, because most of the time it's not inflamed. But you will see that the tendon looks a little bit disorganized. And the particular tendon lies deep to the top superficial tendons is the one that's most commonly involved. So you have your ECRL tendon and your ECU tendon superficially, and just deep to that you have ECRB, and that's commonly the one that's involved.
So
but
that's
not always.
extensor carpi radialis brevis, which is the one. That's why you test the middle finger.
Which is why we do that. So that's commonly the one that's involved, but not always. Sometimes you also have involvement of the ECRL. Sometimes it's involved in the radial collateral ligament as well, which maybe mentioned. And the MRI scan or ultrasound scan will also show you if there's any split or tear in the tendon or any partial detachment. So that may respond differently to all of the treatments, and that can help to kind of guide your advice to the patient, and also guide the prognosis, and can kind of tailor your management depending on that. So I do find that to start with, often I just get an MRI scan.
So if things aren't improving, you would definitely get imaging to find out exactly what's going on, whether there's other structures involved, because that will help guide your treatment.
Absolutely.
Cool. So let's say we've got a diagnosis of tennis elbow. What options would you, and we can talk about this because obviously I'm a physio, so we can talk about like what we would do from a physio point of view. But from your point of view, if you've seen a patient today that you've diagnosed with tennis elbow, they've done nothing so far to help, what sort of advice would you go through with them?
So we kind of tend to think of the treatment of different conditions with some kind of framework, some kind of algorithm that you have with like increasing levels of intervention. So why go for the top level of intervention if you can solve it with the bottom level? Or some step along the way, which is going to be least invasive. So it's best to start with the least invasive and potentially more effective treatments, and then work your way up. So right at the bottom is the thing that patients don't want to hear, which is activity modification.
So if somebody's playing tennis and you say, don't play tennis,
they'll probably carry on playing tennis. But you can tell them, like you said, is that you can tell them to reduce the tennis. To see what happens. So even if you just cut it in half, you play for half an hour rather than an hour, you know, you just play one set, you drop it down, and then see if actually you have any improvement or lessening in your symptoms. So activity modification is key. It's the last thing that people want to hear.
If you just keep doing the same things, it probably won't get better, will it?
True.
Although the research, as we were talking about before, says that in 1 year, 95% of people are better anyway.
So the best single treatment for tennis elbow is just time. And it's really, if you get to that 12-month point, if it's not resolved and you've tried other treatments as well, then you may start to look at surgical options. But you certainly don't need to rush into that. And activity modification, and then all simple things. So you're going to rest it. Physiotherapy is going to be the first thing. So activity modification, but with physiotherapy.
Absolutely.
And
I mean, I'm biased, but I would say, I think from a physio point of view, it's not always that you've got to go and see a physio every week, and they've, you know, sometimes it's just getting good advice as to how to manage it, and then people can go away and try and do it themselves.
You need a good physio is going to give you really clear advice, and as well as doing any kind of deep tissue work, teaches you your exercises. It teaches you a home exercise program that you can do in between sessions, because that's what you need. It's got to be regular. You've got to do it daily.
What about these epiclasps, these sort of braces that you can buy? Is that something that you recommend?
So counterforce brace is essentially a clasp which just clasps around the kind of the top end of the muscles before it gets to the tendinous part. And what that does is, the theory is it just offloads the tendon attachment. And it may be partly the offloading of the tendon, but also the proprioception and the feedback that you get from it that makes your brain think slightly differently about where the position of your elbow is and what those muscles are doing. And it's useful. So it doesn't work for everybody, but there is reasonably good evidence that it can reduce your symptoms while you're wearing it, and particularly while you're doing a heavy activity.
I think that's the key thing, isn't it? Because people always say, well, do I need to wear it all the time? And actually, you don't, do you, necessarily?
No.
It's more about using it when you know you're going to get pain. So if you play tennis and it's painful, it may be worth just trying a brace. Or if you're a manual, you know, I saw a plasterer the other day with it, and you could see he had it on very tight, because you could see the mark on his skin. But he puts it on for when he's plastering, and it seems to help. It doesn't help everybody, but it's worth a go, I think.
It doesn't, and I think it certainly is worth a go. It's cheap, it's straightforward, it's easy. And there is evidence for it that it helps, but there's no evidence that it's going to help the condition improve over time.
No, so it's only when you've got it on,
only while you're wearing
is it actually going to help. And I do also think that you probably need to give it a couple of weeks to see if it's definitely going to change. I mean, put it on, do the thing that hurts, see if it feels better, but you probably need to give it at least a week to see whether overall it changes and offloads the tendon a bit.
So I'm going to ask you a question now.
Yes.
So when we see a patient for the first time and they've come and they've got tennis elbow, we've made the diagnosis, they've had some imaging, and we think, okay, let's start with physiotherapy. What do you start off by teaching patients?
So I think you nailed it at the beginning, modification of activity. So I'm not, unless it's really, really acute, and what I mean by acute is they can't even pick up that cup without getting an hour of pain afterwards. But most patients, you can modify their activity and you don't need to rest them from doing the thing that they love doing. So, for example, tennis or gardening or playing the guitar or whatever it is, normally they can keep doing it to a certain amount, but they need to reduce how much they do it. So, for example, reduce playing tennis by 50% and see what happens to your pain. It's quite clear probably that rest doesn't help tendons generally. And I do believe what happens, people stop playing for 4 weeks, it doesn't really help that much, and they go back The problem is they go back too quickly, whereas actually if you have a period off, you need to then really build it up very slowly, and I think that's really key. From my point of view, people often say, well, do you stretch it or do you strengthen it? I'm not a massive fan of stretching the tendon, because the role of the tendon, it's like a spring. It needs to be able to produce force, absorb force. And so I believe that you need to load the tendon to try and kickstart that healing response and make that tendon more robust so it doesn't have the pain. So I will generally go for a strengthening program, but that could vary from just very simple sort of static strengthening to being in a gym really lifting heavy.
So to that, what you were demonstrating, so I think the classic physiotherapy treatment is eccentric stretching.
Eccentric, yeah.
So it's eccentric stretching, where you're lengthening the muscle and stretching. But then do you do eccentric loading?
So the evidence doesn't support eccentric loading in any more than isometric or concentric. So eccentric is obviously when the muscle is lengthening, but you're loading it throughout. And the evidence, it doesn't matter whether you do eccentric, isometric, or concentric, but you do need to load it. And what I find really, I always start people doing the exercises every other day, because quite often when they're doing the exercises, it feels okay during, but they get a lot of pain after. And I don't really want too much pain after. So I'll probably start them every other day, and then we might go to every day depending on how they're responding. And everybody's different. This is the thing where people Google, they go on YouTube and they say, give me the tennis elbow exercises. And there isn't one exercise that just fixes all. There's always a variety that you need to apply, and every tendon is different in terms of how painful it is, how much it can load, how it responds to load. Sometimes I've had patients where they respond really well to eccentric, but and then the next patient comes in, their eccentric exercises really aggravate it, and you need to go with more of an isometric or concentric. So these different types of muscle activity. So it really does vary, but the principle of physio is a progressive loading program. Now, if somebody gets pain just picking up that cup, I'm going to start them off with a very basic loading program where the load is very light or it's static. But if they only get pain after an hour of tennis, then I'm going to get them in the gym loading a lot heavier, because I want to skip them along that. Yeah, so you're just progressively loading. I prefer to increase weight rather than increase frequency and repetition. So I don't necessarily want them doing it 20 times a week. I'll stick to just every other day or every day, but I will load that tendon very heavily. And I'll start off maybe with more static exercises, so isometric, and then I'll maybe add some eccentric, but I definitely want them doing a concentric eccentric, because
okay, so that's interesting.
That's interesting for me. So it's just, so it's just a simple progression. Now, if you look at the load on a tendon when you're playing tennis, it's extremely high, and that's why they get the pain. So our role as a physiotherapist is to start them off with a basic exercise, but build them up to being able to take the loads of tennis. And this is the key thing. That process, nobody wants to hear it, but that can take 3 months. And people are, don't get me wrong, do I want to do 3 months of exercise to get the pain better? Not really. And people do often drop off on the way. But I find that, and this is the skill of a good physiotherapist, is to make sure the patient is doing it and motivated. I think you have to keep them playing their sport as well. And where then people go wrong is that they say they're playing tennis 3 times a week, and I'm asking them to load 3 times a week, and the overall load is too much. Whereas if I cut them back to twice a week playing tennis, they can still do their 3 times a week.
So there's a lot of art and as well as science and experience as well. I mean, it's your experience of managing different people.
Yeah, with, and as I said, every tennis elbow is different. And I've got, say I've got 5 tennis elbows on my books, say this week. I can tell you now they're all doing different exercises, because one person wants to be a plasterer, the other person wants to play tennis, and then I've got an older lady who just wants to be able to pick up a kettle, which can be quite sore, without pain, and they've all got different exercises. The other things that I'll mention that I quite like is there's something called a flexi bar, which is basically it's what's it made of? Some sort of I don't know what's it made. It's like a dense foam.
Yeah.
And you can do lots of exercises with it. You can get them off Amazon. That's quite useful. And I also like something called a power ball, you seen a power ball?
I have.
And they can be quite useful, but you can't do them with people when they're quite acute. You can only do that when they're further down the line. But I get people in the gym.
Those are quite sort of fun things. Those are things that, you know, people who do, you know, rock climbing and bouldering and martial arts, BJJ stuff, they use that to just kind of warm up wrists and things. So actually you're kind of building in something that's a bit more fun, a bit more functional, and a kind of heading back towards building up towards sports.
And obviously I've been a physio a long time, and I find that one of my roles with patients is to keep them entertained. You know, if you've been given the same exercise to do for 3 months, you'll do it for 2 weeks and you'll never do it again. So compliance of exercise is really important. But that's the physio's job, to keep them motivated, give them goals. You know, you need to get to 6 kilograms on this weight. Great, I'll go away and do it. And that's more the art, the motivational side of it. But also, if they put the work in, there is a high recurrency rate of most tendon complaints. And if you can really put the work in, I think you can protect yourself through strength training, that you don't get that pain again. So all these things can help to motivate people. But that doesn't mean I've fixed every tennis elbow in my life. I really haven't. I honestly think 80% probably get better with a rehab program. And also from a physio point of view, we do some hands-on soft tissue work. Sometimes acupuncture can help with tennis elbow. I'm not a huge advocate, but I've definitely had patients over the years that have found it useful. And it can certainly help with those more irritable cases as well, where pain is overriding their ability to do their exercise.
Yeah, I mean, often when patients come to see me, then they've already had physio. Now, I don't know exactly what form of that physio has taken, but they've often already had physiotherapy. They may have had the problem for several months, and it's really starting to cause a problem. And then just to be told, well, you know, if you wait till 12 months, it'll probably get better because, you know, that figure ranges maybe from 80 to 95% to get better, but not everyone will.
No.
And the longer you goes on, the less likely it is to resolve within that time frame. So we often they often want something additional on top of physiotherapy.
So let's say
by the time they come to see,
because this is really interesting, because you must hear it a lot being a surgeon. I've tried physiotherapy, it hasn't worked, and I think that's one of the things that I find from my experience, because I do lots of injections, and you say, well, what have you tried? Well, I did 2 weeks of this one exercise and it's not better. And I'm like, okay, you haven't exhausted physio. Let's try this. And we also use something called shockwave. So shockwave therapy can help alongside the loading. I wouldn't say it's one or the other. I think it all needs to be done like a sort of multimodal approach to it. And I think if you can do some hands-on treatment with a good rehab program that somebody can comply and commit to with some shockwave therapy, if I had tennis elbow, I would do those 3 things. I'd give it a good go before I thought about.
I was going to ask you, what would you do if you had it?
I would. I think it's a good question. That's what I would do. I would. I play golf, and I do have a little bit of tennis elbow at the moment. I've done absolutely nothing for it, and it seems to be, I don't know if I should say this on camera, it seems to be the more I do, the more golf I play, the better it gets. And that's what's happening. That's what it feels like. And I think there is something in that, because the reason that I got it is because I hadn't played golf for 3 months, and I went and hit a load of balls just at the range, and the next day I started to feel it. So we see it a lot, don't we? When people haven't done something for a long period of time, and then they go and do it, they sort of overdo it. But as I've done more, it's definitely getting better. Now, I would always say, if something's getting better, just keep doing what you're doing. I think we all would, wouldn't we?
Maybe your swing's just getting better.
I wish it was, Henry. I wish it was. But yeah, it seems to be that I'm making my tendon more robust to what I'm doing, stronger, which is why we do rehab with these patients. And I do think it is getting better. So that's quite interesting from being the sort of.
So you mentioned shockwave. And so the next step on from activity modification, physiotherapy, you're looking at non-invasive treatments. So the next level is going to be injections. But before that, you've got shockwave, which is one. Again, there's not a huge amount of evidence for tennis elbow. No. There is evidence in other tendinopathies. And so you can take that and extrapolate that evidence and use it as an adjunct. And I think often it's not going to do harm. It can be a bit painful, but it can often help. You've got similar things. So ultrasound scan, not ultrasound scan, but ultrasound therapy and laser therapy. There's lots of other things which, again, all have kind of low levels of evidence. They may help as an additional or as an adjunct, but any of these single treatments alone is unlikely to solve the problem.
Yeah, absolutely. So let's say they've done brilliant physiotherapy. They've had a bit of shockwave. People ask me, how does shockwave, if you were my patient, you said, I think I want to do shockwave, will it get it better? I would say you have a 50% chance that it may help with your symptoms. So let's say that patient's come back and said, look, I've done everything, Henry. What's next? It's not getting better. I'm not going to wait a year. There's no guarantees it will be better in a year. What about if they started to talk to you about things like steroid injections and injections?
Yeah, so the next level is kind of minimally invasive. So we're talking about injections.
Yeah.
And so the least invasive injection you can have is ultrasound-guided dry needling.
So just explain what that is.
All that means is you have it under ultrasound guidance. So you've got someone like Chris who's got an ultrasound scanner. They put a probe on there and you can identify exactly that spot of the damaged tendon. And you can, with a little bit of local anesthetic through the skin to just reduce some of the pain, you then take a hypodermic needle, the same that you use for the injection, and you actually pepper that tendon origin. And this, along with shockwave and all these other treatments, all they're trying to do is achieve the same thing, which is to stimulate a healing response. Because it's generally not inflammatory, it's degenerate. And so you're trying to actually create a bit of inflammation. You're trying to stimulate a healing response, stimulate a little bit of trauma. And you want that tendon to kind of regenerate and start to perhaps even heal back down to the bone a bit better. So ultrasound-guided dry needling. It's minimally invasive, the risks are low, and it can often be effective. And there is evidence for that. Yeah,
there is. And I do it, and I normally do one sitting. They go away. It's quite sore after. You can't take anti-inflammatories for the reason you said. And then I might repeat it in 4 to 6 weeks, depending on how they've responded. But hopefully, if it's going in the right direction, then you can continue. So that's...
It can be a bit sore, but it does.
Well, it can be sore after, can't it? Yeah. Okay, steroid injection. We always get questions, what about a steroid injection? 20 years ago...
Everyone would have got a steroid injection.
Everybody would have got a steroid injection, yeah.
So the condition is not new. Tennis elbow is not new. It was described in 1883 as tennis elbow. And they kind of even then had an idea of actually what it was. And then in the 1970s, they kind of got a better idea of actually what the pathological process that was happening. It was not inflammatory.
Yeah.
It was actually a degenerative condition. And if you see it, if you have an operation, you see this tendon and it just doesn't look happy. And so the surrounding tendons all look nice and white and shiny and linear, and all the collagen fibers are nicely aligned. And then you see this dodgy bit of tendon that's grey and friable and slightly mushy, and it's clearly not a functional tendon. And you think, well, it's no wonder that that's causing pain. And so with steroid injections, it is something which, like you said, 20 years ago, even 10 years ago, it was very common.
Even now, actually. There's still a lot of
certain places we use it quite a lot. But actually, there's very little evidence that it's going to improve the condition. In fact, it is the one treatment where there is the most evidence that it's actually might make it worse, and it can definitely slow down your recovery overall. But in certain circumstances, sometimes if you've got something else there as well, or if you need it for a very specific reason, it can give you good short-term relief. So it can be effective at giving you short-term pain relief. It does not solve the problem. It does not make it better. It doesn't work long-term.
And what I find is that from when we were doing a lot of it before, you do the injection, they love you for 3 months, and then they get this real bounce back pain. That rebound pain where they're probably worse off than if you hadn't done it. I actually did one the other day on a manual worker who was self-employed, is on a day rate, and he needed to get back to work to pay his bills. And so I always think there's the odd occasion where you may do it. But overall, we try and avoid that now, don't we? What about something called PRP? Because this is getting quite a lot of press. Do you want to explain what PRP is and what it's used for?
PRP is platelet-rich plasma, which is essentially you take some of your own blood, it gets spun down in a centrifuge, and then you take the pro-healing portion of that along with platelets, and you lose the kind of pro-inflammatory part. And that's all it is. It's just your own blood spun down, and you're just taking the good part, and maybe not the part which is going to stimulate inflammation and pain, but you want the stuff which is going to stimulate healing and regrowth. Again, there is some evidence, but not a huge amount.
It's not that strong.
It's something where it will show a difference, a positive difference in some studies, but not other studies. So not every study is giving us the same answers. And again, in certain circumstances, it can be very useful. I would say that's my second line injection after dry needling. So ultrasound-guided dry needling, followed by dry needling plus PRP.
Yeah. So you can do the two together.
And
we were talking about it before, but you talked about that sometimes you might favour PRP if when you do your imaging that you see a big tear because you're trying to heal that tear, obviously. Would that be the case?
Yeah. So going back to that MRI scan, if you've got it on the MRI scan, you've got an obvious split or a tear in one of the tendons, and it's normally that ECRB tendon that we mentioned. Yeah. Or if you've got maybe a partial detachment of the actual origin of the tendon from bone, then that's going to guide your treatment in a slightly different direction.
Yeah.
So that may be why they're just not recovering. They're not getting better. Even they are doing the physiotherapy. They've had dry needling. It's just not improving.
Yeah.
And these are the patients that possibly PRP, but these are the patients that are the ones that end up needing an operation.
So coming to an end now, this is the bit I really want to get to. So as a surgeon, when would you operate on a tennis elbow? And I don't know if this is a silly question, but, well, first of all, would you have a surgery for tennis elbow? But how successful is it? You know, when you do an operation, you're like, this is a good operation. I know this helps a majority of my clients. Is that how you would go into a tennis elbow injection? Or is it a little bit more not sure?
With an operation?
Yeah.
So by the time that you've climbed that intervention ladder and you've tried the other treatments and they have not worked, or there's a clear problem where you've got actually maybe a more significant tendon detachment, that's slightly different.
Yeah.
But let's say if you don't have a tendon detachment, but you've got a bit of a split, you've got tennis elbow, you've got that obvious degeneration on the scan, it is actually, an operation is successful. I mean, you get good results in over 80%.
Yeah.
I mean, it's a good treatment. So this is an operation which was described in the 1970s by Nerschel, and it's very straightforward. You make a small incision over that tendon origin, and you identify the damaged and kind of unhealthy looking tendon.
Yeah.
You preserve all of the healthy looking tendons over the top. You can just split between the fibers, and you take out a portion of the damaged tendon.
Pull it out.
Well, it's sort of cut it out neatly, but yeah. And then you actually, again, you want to stimulate a healing response.
Yeah.
So you either petalize the bone, so you're picking little curls of little bone off there with a tiny little chisel, or with a very small wire or drill. You're going to make some little drill holes into the bone because you want bone marrow. And
you want
that's like your local PRP.
Yeah.
It's full of healing factors and growth factors, and you want bleeding because the bleeding from the bone will form a clot, and that's going to help that tendon heal back down to bone nicely. Yeah. Sometimes you will need to detach the tendon and reattach it with what we call an anchor into the bone, which is either like a little plastic or absorbable tack or a screw, or sometimes just an all suture soft anchor. And those are where you tend to have a bit of a partial detachment to begin with.
Yeah.
Or if it's more severe and you need to get more of the tendon, you have to do a bit more of an extensive repair. We will also repair it back down to bone. But the key is getting that bleeding, getting that bone marrow, that good bone marrow stuff out of there.
Yeah, so it's not as if you're sort of, you're repairing something, but you're also trying to stimulate the healing response, as you say, by drilling. So if you've just had a tennis elbow, like how long does it take? People always say, well, when will I be better, doctor? So how long does it take for these to feel much better after surgery? Because I assume you're quite limited at the beginning.
Yeah, we tend to sort of slow people down at the beginning, really, because you just want them to rest there. You give them a sling for comfort. You don't have to wear it all the time. There's no set restrictions. You're not in a cast or a brace or anything like that.
Yeah.
But you just want to just let things settle, particularly if you've had a tendon repair.
Yeah.
So you're going to take it slowly for the first few weeks, and then you're going to see someone like yourself, and then start with that physio process. And part of that is just getting range of movement back. Yeah. And once you get range of movement back, the first exercise is going to be isometrics. Yeah. So no tendon kind of lengthening or static.
Yeah, exactly. Perfect.
So gradual static reloading of the tendon, and then you move on to concentric and eccentric exercise.
And if you say that you had a tennis player, when would you expect them to get back on the court?
Following an operation.
Yeah.
It will vary, but you can probably with your physiotherapy, you're going to build up to about 12 weeks.
Yeah.
And about 12 weeks, it should feel pretty good. You got your range back, everything feels okay. You've done some strengthening, but the key is not to go back too early.
Yeah.
Because it's not just the little operation that you've had. It's the fact that your whole arm is deconditioned.
Yeah.
Everything is deconditioned. You lose muscle mass throughout.
Yeah.
And that is what's going to cause you a problem if you just go back to playing tennis. Yeah. So again, like you're doing gradual reloading of the tendon, you then want to have that gradual return to play and continue with strengthening the rest of your upper limb.
We've got one at the moment, and they're back, but it's about 5 months. Yeah. So it takes
from 3 months. That's not going to get you back to playing competitive tennis and
just varies,
5 sets.
But this person was quite deconditioned before, so we've delayed them a bit, but they are doing very well. So hopefully they're back. Brilliant. Would you have surgery if you had tennis elbow?
I think I'd come and see you first.
Yeah.
Do the physio.
Yeah. So you'd exhaust all your options. I think that's.
And then climb up the ladder. And then if you need it, go for the guided injection. And again, you know, you may add that in with something else like shockwave, because, you know, although I'm a surgeon and I love fixing things, love operating and fixing things. It's very rewarding and it's great drilling things.
Yeah.
But actually, if you can get it to heal before you get to that point, that's the best outcome.
Yeah. Absolutely.
And for most patients, that will be the case.
Yeah. And as a final motivating message, as you said, 80 to 95% of these get better on their own, don't they? So I think people need to hold on to that.
Give it time.
Yeah. And
activity modification, cut your tennis time down a bit.
Yeah. Brilliant.
And it will get better.
Excellent. Thank you very much for joining us, Henry.
Thank you very much, Chris. Thank you.